My topic is Lumacaftor, Ivacaftor in patients with cystic fibrosis, homozygous for the PHE508del CFTR. Cystic fibrosis is a genetic disease that is associated with high rates of premature death. It is a multisystem disease that is characterized by pancreatic insufficiency and chronic airway infections associated with loss of lung function, repeated pulmonary exacerbations, and ultimately respiratory failure. Cystic fibrosis is caused by gene mutations that result in deficient or dysfunctional cystic fibrosis transmembrane conductance regulator (CFTR) protein, an anion channel that is normally present in the epithelial membrane. PHE508 del is the most common CFTR mutation. Approximately 45% of patients with cystic fibrosis are homozygous for this allele. Cystic fibrosis is a progressive disease. Despite advances in therapies designed to address the symptoms of the disease, the median predicted survival among patients who are homozygous for PHE508del in the United States is 37 years. The PHE508del CFTR mutation causes a processing defect that severely reduces protein levels at the epithelial membrane. For the few channels that reach the cell surface, the mutation also disrupts channel opening. Together, these effects lead to minimal CFTR chloride transport activity. One approach to treating cystic fibrosis is to address the underlying cause of the disease by targeting the CFTR protein dysfunction. Lumacaftor is an investigational CFTR corrector that has been shown in vitro to correct PHE508 del CFTR, processing and increase the amount of cell surface localized protein. Ivacaftor is an approved CFTR potentiator that increases the open probability of CFTR channels in vitro and improves clinical outcomes in patients 6 years of age or older who have cystic fibrosis and at least one copy of most class 3 mutations. The combination of Lumacaftor with Ivacaftor has been associated with a greater increase in chloride transport than has either agent alone. Neither Ivacaftor nor Lumacaftor monotherapy has been shown to have meaningful clinical efficacy in patients who are homozygous for the PHE508del CFTR mutation. Methods. The traffic and transfer trials were two phase 3 multinational randomized double-blind placebo-controlled parallel group studies in which Lumacaftor was orally administered in combination with Ivacaftor for 24 weeks. Results. The percentage of patients who had a relative improvement in the percentage of predicted FEV1 of 5% or higher was greater in Lumacaftor Ivacaftor groups than in the placebo group. Clinically, meaningful reductions in the rates of protocol-defined pulmonary exacerbations were seen in both Lumacaftor Ivacaftor dose groups. Results. Over the course of the 24-week period, the mean BMI, the weight in kilograms divided by the square of the height in meters, increased steadily in both Lumacaftor and Ivacaftor dose groups. Conclusion. This data show that Lumacaftor in combination with Ivacaftor provided a benefit for patients with cystic fibrosis homozygous for the PHE508 del CFTR mutation. Lumacaftor-Ivacaftor combination therapy resulted in improvements in multiple clinical endpoints, and the findings were generally consistent across those groups and studies. Clinically important reductions in the rate of pulmonary exacerbations were also observed in association with Lumacaftor-Ivacaftor